Good morning, everybody, and good afternoon. Those are in the other side of the globe. It's my pleasure to introduce this panel and moderate this panel. But first of all, thank you for the organizers for organizing this crucial event at the crucial time, and also giving us this opportunity and privilege to be presenting the research that we are involved in. Now, I would like to introduce the panelists. Those are with me uh, in the sequence that they are presenting. But first, I would like to introduce Dr. Imran. Dr. Mohammad Imran, he is a fellow College of Physicians and Surgeons, Pakistan, and a pulmonologist by training. He's a medical member of the American College of Chest Physicians and a consultant pulmonologist and a clinician lead for the COVID-19 hospital in Peshawar, also Medical Emergency and Resilience Foundation. And Dr. Imran and Dr. Sajjad, who is also joining us here, has led this project that they are presenting, which was conducted on the border of Pakistan and Afghanistan. Dr. Sajjad, after completing his MBBS degree in Pakistan in 2014, went on to pursue a MPH, the Masters of Public Health, with concentration in global health at the University of Arizona in United States as a Fulbright scholar. After completing his MPH successfully, he was working for 3 years with WHO, mainly in the polio eradication program. And since the start of this COVID-19 pandemic, he was involved heavily in the WHO and the Medical Emergency and Resilience Foundation's work in COVID-19 response. Currently, Dr. Sajjad Khan is pursuing his PhD from Indiana University in USA in environmental health with concentration in environmental epidemiology. As you can imagine, this is a very important connection to the COVID-19 and all such epidemics and pandemics. So without further ado, Dr. Mohammad Imran and Dr. Sajjad Khan's project will be presented by Sajjad. Go ahead, Sajjad.
Thank you so much, Dr. Pakhale, for your introduction. Preshit is sharing the screen, and so I'm just. Can you go? Yeah, the next slide. I'll be. This is the summary slide for COVID-19 response in Pakistan. So we will give an overview of COVID-19 response in the country, and then we'll talk briefly about the summary of health system's response, like how the health system responded, and then an overview of the economic and social and cultural impacts, and lastly, we will discuss the summary of Pakistan-Afghanistan border study that we were involved in conducting. So the next slide. This slide shows as we can see that it is the overall summary of COVID-19 pandemic in the country. Is the right graph shows that we had 4 waves. The first wave started in March, and then the second one in November, and then the third one, and then the last. This one is the fourth wave, which is now in the receding phase. In the right side of the graph, we can see the positivity in the first. In the first wave, the positivity touched around, mostly it was above 20% because we were conducting very less tests. And then after that, the positivity in the second wave was around 6 to 7%. And then in the third wave, it reached around 10%. And now in this wave, it was around 6 to 7% again. So this means that in the last 3 waves, we were conducting enough tests to detect outbreaks. But in the first wave, the number of tests were not adequate, and we will discuss it in the in the health system response too. Next, please. In this slide, we can see the number of tests that were conducted per 1,000 people, and we have compared the few countries like we can see Pakistan and Bangladesh have conducted very less tests as compared to India and Iran. And the COVID-19 stringency index is that it shows the response of the government. So that how stringent the government response was, like how were the offices closed, were the schools were closed, there were like restrictions on movement and all those things. So this shows that in the first wave it was pretty stringent. The government response was pretty stringent, and in the later waves, the country has adopted this new strategy, which is called smart lockdown. They call it smart lockdown, and it's like implemented in the hotspot areas, like wherever we have hotspots, and then that's how it's implemented. Um, then with the uh, as we can see in the different waves, it was the country's response was seen as that. And then recently, as we have seen that like the country has in all these waves, like there were sometimes they were opening offices, then they were closing it, and then like different strategies were used to curb the transmission of COVID-19. Next, please. This slide is an important slide, and we included this just to see the this is taken from the Institute of Health Metrics and Evaluation, and it shows the number of reported deaths till October 13. It were 28,000, while the total number of deaths that they have projected is around 400, it's 441,000, which is like a gross extra, which is like around a number of times more than the actually reported one. So I want to touch upon a few things and that can give us the idea. As we have, as me and Dr. Imran were involved in the hospital too, and we can see that how the deaths were reported. So in Pakistan, when the deaths are reported, when a death occurs within the 14 days of a positive PCR, that is counted as a COVID-19 death. But that is not always the case. Sometimes are like like there is a chance that a person has a positive test and he or she dies after 14 days, so which is not technically counted as a COVID-19 death, but it's due to the COVID-19. And different countries have different counting strategies for that. Another issue that we have also seen in our hospital was that like there were a lot of cases which were clinically and radiologically, clinically, and they were COVID-19, but but the tests were both the PCR and the rapid antigen test would be negative. So that's how the number of deaths. Another issue is that a lot of people were not even conducting, they did not have either access to test, or they did not wanted to conduct the test, because we will talk later in the socioeconomic and cultural impacts, that there was a big stigma with the disease too. It was associated with the test because there were the different issues. We will talk about that in the slide on the cultural socioeconomic and the socioeconomic impacts. So this was about like we can go to the next slide. So this we are just coming into the health system response. That's why we have included this slide. It shows that how different countries are spending a percentage of GDP on health. So as we can see that Pakistan and India and Bangladesh, all of them are in the South Asia. So they're spending less than 5% of GDP on health. And if we compare that with other countries such as Norway, Brazil, United Kingdom, and Iran, they're spending upwards of 7 and 8% on health, on the health. So it shows that the countries like such as Pakistan, India, and Bangladesh need to spend more on the health system so that we can have a robust response. So that's why we just they like to give an overview of the health system. That's why we have included this slide. Next, please. So here we want to focus on these four aspects of the health system's response. So we will be starting. I'll be. I just want to present the disease surveillance. This was a novel virus, a novel disease in the country and in the whole world, I would say, and how the country or how how we responded to it. So starting from the testing capacities, like we did not have any. There were just at the start of the pandemic, there were just a few labs, and the major one was National Institute of Health in the capital Islamabad. Other than that, like the province that we are from, we did not have any lab which can test, which can do PCR for COVID-19. So they started to the first test from all the provinces. We would be sending tests to NIH, and then after that the provinces also started to have their own tests. Like I can give the example of Khyber Pakhtunkhwa province, there from which we come. So the Khyber Medical University started their testing, and then after that they made now currently they were expanding the testing capacities, and currently there are more than 17 to 18 labs which are conducting PCR, and the daily capacity was less than 500, and now it's more than 10, like more than 6 7,000 PCR tests. Another important point is that the government has introduced that rapid antigen test, which was freely available to the hospitals, and in some hospitals there was the issue of access, but in most hospitals it was available. Then the community outreach was done, like in the first when there were when before the community spread, there were like localized outbreaks. So for that, the country, like Pakistan has a pretty, I would say, like the an expanded primary health care infrastructure. So we were using the expanded program on immunization, the lady health workers program, and all those people who were involved in the community outreach to tell people and to to do contact tracing, and to in the first wave, as the people coming from China, or for people coming from Iran, or even from the Gulf countries, because there are a lot of people coming from. There were a lot of people. So I can just give an example that in the first week, like after 12th March till 18th March, around 12,000 people entered Khyber Pakhtunkhwa from outside. So they gave out the lists to all these. Expanded program on immunization technicians and like lady health workers, and they were supposed to trace those people and like to trace them for symptoms and then conducting the test. So that's how the country started to do there. And then lastly, I just want to say about the lockdown and the non-pharmaceutical measures. So the country implemented a very strict lockdown after 18th March 2020 till mid May, and after that they started to relax it a bit, and then like opening businesses and those things. So, and then secondly, we want to focus on the healthcare capacity, like all the existing healthcare staff were trained on COVID-19, and testing, and on clinical response, and on contact tracing, and all those things, and like in the and infection prevention and control in this in the scenario of COVID pandemic. And then the important point is the expansion of ICU and HDU services, how that was done. And then the medical oxygen is an important issue, because in COVID-19 the patients need oxygen. So for that, there are different kinds, like you can use a cylinder or liquefier oxygen. So those were expanded to different hospitals, and they were conducted. Lastly, the vaccination was rolled out multiple weeks. In Pakistan, we started from the Chinese vaccine, like Sinopharm, and then Sinovac vaccine, and then lastly the Oxford AstraZeneca, Pfizer and Moderna vaccine. They were introduced. So, and the country has a pretty stringent policy regarding vaccination. That it was mandatory. It is mandatory, and nowadays they are doing it in a mandatory way. But it has also created some issues about regarding we need to have more risk communication, and that's the strategy for that. And then in the first wave, the COVID-19 has an impact on the childhood immunization, and the immunization rates dropped due to that. Next, please. So here we want to talk about the socioeconomic and cultural impacts. So just to focus on these four things, the first things that we included is disease stigma due to the isolation and quarantine measures, and due to this new disease and due to the infectious nature, there was this disease stigma. Like I can give you an example that when where at the first there this when there was when someone would be infected with COVID-19, they would strictly implement isolation and quarantine, and police and law enforcement agencies were involved in the lockdowns and in restricting movement for people who had COVID-19. So this created a stigma there for the disease. Secondly, in a region like ours, we had it's a war like there were different militancy and wars before that, so there was a lack of trust with the government and with all those things. And lastly, there was an important thing, which is the people who dies from COVID-19. So there were like strict implementation of burial procedures. So and in our part of the world, we had like almost everywhere there's like a cultural way of burying the dead and conducting the different funerals and all those things. So the government was not allowing that, and that created a lot of miscommunications and like propaganda and all those things. So I would say that the government should have taken people or public in confidence before implementing those procedures. Like we could have done different surveys, like it happened with the Ebola outbreak too. In West Africa, that when the burial of the dead or those things, the different funerals were conducted in the way they want to curb the infection, so that created issues. So it was similar. Lastly, coming to the economic impacts, is that during the lockdown, we will focus in the next few slides that daily wage laborers, small businesses were affected, and there was impact on poverty. But the country had this stimulus emergency response package called SAS Program. SAS is the Urdu word for like feelings and that. So there's this program, and they affected the the overall economic stimulus. Next, please. Here, I would just want to focus we the poverty rate during the lockdown. So the base rate is 27%, and as we can see that after the lockdown was implemented, there was a profound economic slump during April and May 2020, and and the non-poor population temporarily slid into the poverty line. And this study is taken they conducted this study, and that the poverty rate in Pakistan reached 43% in April and declined to 38.7% in May. And there was a rapid decline, but rapid decline in poverty due to the due to reopening of economy. As I said, that it was reopened in May, and in the government emergency response packages. Next, please. Here is we have just given the different mitigation measures that the government did. It was a SAS cash program in which they distributed about 873 million rupees and $873 million. And similarly, with support package for labor, then subsidy for utility store corporation. That's like stores which support, which from which poor people can get their daily daily use things. And similarly, electricity relief package was given, and then financial support for the private companies, then wheat procurement and agricultural packages. So these were just like a summary of that. Next, please. Here, I want to just see the impact of the SAS program. So SAS, it was mostly direct liquidity injection to poor household, and the national poverty rate decreased by 11.2%, and rural and urban poverty rates decreased by 14 and 7% due to the injection of this liquidity cash. Next, please. So in the next few slides, I would just want to focus on the Pakistan-Afghanistan border study. So this was a study that we conducted in our our objective was to determine the period prevalence in all the healthy residents of 4 quarantine facilities located in District Khyber at Pakistan-Afghanistan border. So in this study, initially all the symptomatic individuals were excluded and they were referred to the district headquarter hospitals, while all the healthy asymptomatic travelers that came from Afghanistan and they were from Pakistan, and it included people who were involved in they were driver or they were either taxi driver, they were business people, they were so they went they underwent the screening, and then all the positive individuals were followed in the quarantine centers, while those who came negative were sent home, and those who were positive were sent into the quarantine center, and they were followed for the next 10 to 15 days for any symptoms, and we'll go into the details in the next slide. So in the next slide shows the flow diagram. As we can see that we had 847 travelers, then 139 were symptomatic. They were sent to hospital, and then 708 were asymptomatic. And then we had like positive 68 people in the 708, negative were 596. The inconclusive went again through test, and in that we had 4 positive and like 3 were negative, 3 were inconclusive, and 38 were negative. So so in the overall, like we had 708 individuals were tested, and of that 68 were positive, and then 3 more were added later on. So uh, based on that, we calculated the period prevalence, and then the association of positive test and individuals' age, sex, and occupation were assessed using chi-square and mental Hansel tests, and logistic regression was used to calculate odds ratio for each age group adjusted for sex and occupation, and then time to event analysis was also conducted. We will talk in the results section about this. Next, please. Here, we just want to focus on the main results. And this taxi driver had a higher odds of the odds of 4.08, and the p-value was less than 0.001 than the non-driver. So it shows that like taxi driver had this was considered a risky profession according to the data, and there was high probability of positive testing between 41 to 60 age 2. So in this age, and the taxi drivers were conducted were having more chance of being positive. The next slide shows the symptomatic versus asymptomatic and the CAM curve for that. So symptomatic people, the median infectivity time was 26 days, while for asymptomatic it was 14 days. So it shows that people who were symptomatic had a higher chance of spreading the virus during like those days as compared to asymptomatic people. Next, please. Here, this shows the hazard ratio, and it shows that symptomatic individual had a higher risk of staying COVID-19 positive for longer period, and we after controlling for other factors. This shows that. Next, please. So summary of this study was that we had 10% positivity and largely asymptomatic, and the importance of pre-symptomatic time that we had we had as a percentage of people who were asymptomatic and then they developed symptoms. So that was the importance of the pre-symptomatic time. Younger individuals are less symptomatic as demonstrated in the results section, and testing capacities. So for due to to catch or to I would say to detect the people who are pre-symptomatic, so we need to conduct more tests. As everyone is saying that we need to have more tests so that we can we can diagnose the people who are asymptomatic or who are pre-symptomatic at the time, and for that we would need to have more tests, and we have to isolate the people, isolate the timely isolation of the cases who are in pre-symptomatic phase. So this was just the conclusion of this study. This is the summary of that conclusion. Next, please. Yeah, so these are just the references that we have used. And now I would request Dr. Pakhale to go onwards.
Thank you so very much, Sajjad. That was a very comprehensive presentation of what was happening in Pakistan at that time and ongoing. I don't know, maybe we could ask some questions around this time if there are any questions in the audience, or I'll get started. Maybe Dr. Imran, you can tell us, because you are hands on where the action was happening, and when the isolation practices and the testing, is the facility still ongoing, and are the rates similar? Or you said the taxi driver were more infectious and they were more positive cases. Is that the same now, or has it changed? Like, what are the socio demographics?
Thank you, Dr. Pakhale, for giving me the opportunity. The thing is almost the same. Like initially, this study was done after the first wave, and there was a sharp decrease in the number of cases and the positivity of the first wave. But then the second wave emerged, and the thing was again like the asymptomatic people were spreading the virus, and the older age people were coming to the hospitals. So in Pakistan, like as Sajjad said, the number of actual deaths, they are far less than the projected deaths. But there are some reasons for it. Like we have a younger population. Average age here in Pakistan is 22 years. So a lot of people are in the young age group. They remain asymptomatic and then they carry the virus and infect the elderly, and then the elderly present to the hospital. So that is the normal routine in all of the waves. But the positivity has remained as we compare it to the region. So the positivity has remained in the lower limits in all of the last 3 years, like in the second, third, and fourth. It has the peak is around 10%, and then again it has come down to below 1%. So uh, the waves are behaving almost in similar fashion.
Interesting. Now, you guys were at the border near the province where you're from, but what about the other borders? Were they also similarly monitored? Were there other quarantine centers at all the borders around Pakistan?
In Pakistan, initially, around most of the borders, they were quarantine center, and anybody who were getting into the country, they were screened at the border, and those with symptoms were referred directly to hospitals, and those who were not with any active symptoms, they were quarantined for 14 days in different quarantine centers. And there we conducted this study. This was from 15th to 25th April, so this was in the span of 10 days. But this was a continuous process. Like daily, there would be 300 to 400 incumbents into the quarantine centers, and they would be tested regularly. And then the positive ones would be staying there in the quarantine center, and the negatives and those who became negative were then sent to their homes or to their respective businesses, etc. So in those days, the majority of the positive cases were drivers, like the truck and the taxi drivers, which can be explained by the fact that, given the fact that the health system in Afghanistan is very much lagging behind the that of Pakistan. So most of the patients they try to visit Pakistan for seeking healthcare services, and these taxi drivers they usually carry those patients. So they are a big source of spreading this infection from patients to healthier ones. And the quarantine centers are still there. Like anyone, like there are testing centers at the airports and at the borders even now. And anybody who enters Pakistan is tested at the airport, and then if their test is positive, so they are then referred to quarantine centers if they are asymptomatic, and if they are symptomatic, then they are referred to hospitals.
Mhm. I do not see any questions from the audience, so I'll continue. Um, I was very impressed with the SAS program and giving the cash, because that's very important in such kind of a very challenging and needy times. Even Canadian government in Canada here did the same thing. There was a program for money for people who are in dire need. Now, this SAS program, which gave the cash to people in rural and urban areas, I understand, is it still ongoing, or has it been stopped?
Basically, this SAS program was started way back with the name of Benazir Income Support Program, which was in the name of the martyred Prime Minister Benazir Bhutto. So this program is going on from there, and from the current government. And when this pandemic hits the country, so the data of that Venezuelan income support program or the SAS program was used because that was a comprehensive data, and poverty scores were given to various families. So the poorest of the poor, they were given the priority, and they were given these liquidity injections in the form of cash grants, and it's still going on. Like it was there before the pandemic, and it's still going on. But the subsidy was like extended to some utility items, some groceries. Um but again, like we have a population of 220 million people, so it's difficult to reach each and everyone. We are lagging behind in proper data collection, in proper documentation, and that is one of the questions which is being raised by the international community on the low numbers of cases and deaths in Pakistan. That it is like the proper reporting of cases. We are getting very less number of patients to the hospital because of the social stigmas related to it, to the COVID. Most of the patients, they stay at home. They don't visit hospitals. And again, like the criteria which is being set by the government for a positive case, it is very irrational. Like in our hospital where I am working, till now, we have total deaths of around about 300, but COVID positive deaths are only 50. So it's 6 times less. Like anyone who dies and whose PCR or rate is negative, he's not counted in the COVID death. So that is a very strange criteria for it. Like there is no clinical or radiological explanation for COVID. So that is one of the reasons. Like that's true that government has done some of the liquidity injection, or they have given cash grants, but they haven't reached each and everybody. There are still people suffering. The daily wages have lost their jobs. Small industries have closed down, and now this recent price hikes in petroleum and grocery prices, they have hit the population really, really badly. So measures are still needed.
Mhm. Indeed, indeed. I mean, underreporting has been the, you know, universal, I must say, with COVID-19 pandemic, and underreporting was even discussed in terms of New York deaths and everywhere. But underreporting from India and Pakistan is at some other level, as we know, as Sajjad reported that data on actual number of reported deaths and what presumed to be the COVID-19 deaths is, you know, over 20, 25 times more. And that's astronomical. And if that is the figure of deaths, then you can only imagine how many people are suffering the consequences of it, because many times these were the breadwinners, like the taxi driver you said, were the breadwinners of the family, and then the family gets pushed into further down in poverty. So those are the, again, lessons of COVID, even from rich countries like Canada and United States, where people who were marginalized and already living on the margins of the society got pushed further down. So Sajjad, or you might know, what is the vaccination rate now in Pakistan? Or Imran, whosoever knows the current vaccination
Yeah.
rate for COVID-19, I mean?
Sajjad was leading our facility. I am still working here, and he has left for his PhD there. So we have a community vaccination center in our hospital as well, and the government have established such type of centers around the country. So the vaccination is getting pace. It was slow in the start. Pakistan was elected in getting vaccine. Like then the China, as usual, came to our help, and they provided vaccine in aid, and even the vaccine was rolled out before the tested results were there, the Chinese vaccine. So, but now we have Moderna, Pfizer, and the community vaccination centers have also been there around the country, and I think they are now. Sajjad will properly tell, but they are now vaccinating almost. Sajjad, can you correct me? Is it
Yeah,
in it's 7 to 800,000 per day?
yeah. So the country, I just we also wrote this editorial for APSR journal, in which we also included
I
at
wrote.
that time. Yeah, at that time we also included the vaccination rates that the country was using more like a donation things, and they were not purchasing the vaccine, so it was very low. but then at the peak, like it has reached 100, like 1 million doses per day. It reached more than 1 million doses per day, and now I think it's upwards of, like, the first doses about, like, in 30% around that people have taken the first dose, and like the fully vaccinated are around 20%. That's not that much. And the main issue in the first few months was the supply issue. People were still eager to that. But another thing that I want to mention is that, like, the proper risk communication and community engagement wasn't done, and there were a lot of conspiracy theories that the vaccine are not good, and like it can harm you, it can do this, it can do that. We also did a survey on that too, in the healthcare workers, and that data we are doing the we are analyzing the data, and that like the healthcare workers, the doctors, and the technicians and nurses and all those people, there was a lot, there was vaccine skepticism in them too, and most of the issues were related to the side effects, or the approval process, and the efficacy. So, but the country has taken the pace now, and they have now it has reached like more than a million. Yeah.
Interesting. Yes, I mean, the pandemic was unfolding. The pandemic of fake news was also ravaging, and we had a lot of, unfortunate effects because of the misleading information, which is readily available for all people globally. And, most affected got those who already were affected by the pandemic's socioeconomic effects. We have a question.
Currently, there's a question in the,
There's a question in the from the audience, and this is an interesting question. And if Sajjad or Imran, anybody, you can take the current preparations for future waves of COVID in Pakistan and India. Are there any current preparation? Is there any pandemic preparedness program going on in Pakistan?
Yeah, the country is, I would say the country is the signatory of the global the I think it's and the laws were passed in like 2005 to report all the diseases and that. So I think the current the future preparations is that, as I said, that the country has invested in ICU and HDU services. Like as we can see that in the whole province, we are from, we had just like 34 functional ventilators in the whole province. Now it's like more than 300 functional ventilators, I would say. So similarly, as I said, that they invested in, like, they trained all the people on the infection prevention and control strategies. So similarly, as I said, that the country has this smart lockdown strategy in which they impose lockdowns, or they impose non-pharmaceutical interventions in the hotspots. Like I can give the example of this year's Ramadan, like the month in which the people are fasting. So it was at that time, it was like the infection rate was really high. So what the country did was that they closed down the markets and all those things after 6 p.m., and it was, they were supposed to open at like morning at 9 from 9 to 6. After that, everything was closed. So it really brought down the infections very low. Similarly, like I can give you an example of one district in which the positivity reached around 40%. So what the administration did, that they imposed lockdown in that specific city, and after a few days the infection rates went down. So that's how they're preparing for it. But I would say that still we need to do a lot if there's any another virus or another disease. So like similarly, nowadays we have a dengue outbreak going on in Peshawar. So we are not that much prepared, but still, like, this pandemic has told us it has shown us that we are lacking in what we can do. We know the issues, now we have to work on it more in the future.
I want to add a sentence here that COVID really has been lenient on us. Like there are infections, but the patient presenting to the hospital, they are very much low as compared to to other countries in the region. But once, like if things get out of then we have nothing in hand to cater to those patients. Like Sajjad said, before the pandemic started, there were only 34 functional ventilators in the country with not a single intensivist here trained. Now we have invested a little bit, but that's very much low to deal with the pandemic in the form of it is spreading in Brazil or it has spread in Italy. Like if that thing came here in Pakistan, then there will be nothing. We have we have no infrastructure to cater that thing.
Yes, COVID-19 has taught a lot of important lessons going forward for many countries, rich and poor alike. And I hope we take those lessons and implement those, because first thing first, we got to improve the healthcare spending compared to GDP. And unless there is a investment, I think this kind of a pandemic preparedness will not come. Getting the PPE or vaccination, hospitals which are well equipped to deal with isolation, quarantine, testing, tracking, and ICU capacity. I think that was a great discussion. Thank you, both of you. And we will go on to our next segment, COVID-19 response in India. And this will be presented by Preshit, who is currently a postdoc fellow at the Ottawa Hospital Research Institute. But before that, Preshit completed his BMS degree in India and then went on to get his doctorate in health policy from University of Arizona in America, in USA. And he completed that and joined us as a postdoctoral fellow at the Ottawa Hospital Research Institute. And currently he's working on his postdoctoral fellowship. So without further ado, Preshit, take it away.
Thank you, Dr. Pakhale, and good morning and good afternoon to everyone. Keeping in mind the theme of the conference, in my presentation, first I will be discussing one of our study which we did based on the earlier pandemic wave in India, and what was its implication in terms of cost. Then I will discuss what has happened in India after that first wave very briefly, and then I will go to the to discuss the impact of this pandemic in different aspects of the society, and based on a study, anecdotal evidences, and literature, we'll discuss some lessons, what is there for India. So to refresh our memories, how pandemic started in India, the first COVID-19 case was reported in 30th of January 2020 in the country. And soon after that, country actually imposed a 3-week lockdown starting from 24th of March, which was widely praised that at that time, even by World Health Organization, WHO. But as we know, right now, India is reporting the second highest COVID-19 cases in entire world. And within India, there is a huge differences in terms of COVID-19 cases across the states, and state of Maharashtra, as shown here, was reporting the highest number of COVID-19 cases, and so as COVID-19 deaths also. But we have to keep in mind when we see these numbers that particularly for Maharashtra, as I was hinting, there is a disparity across the states. States like Maharashtra, Tamil Nadu, Kerala had a very stronger healthcare systems and data reporting system, and that's why it's quite possible that what we are seeing in terms of numbers from these states were very closer to the actual reality when we compare to the other states in the country. So as Maharashtra was drawing more number of cases for my study, I focused my attention on this state. And just to give you a background how Maharashtra implemented lockdown in within its jurisdiction. First case in Maharashtra was reported on 9th of March. And the pre-lockdown phase, like the days before Government of India imposed the first lockdown, that spanned about 16 days. And the first phase of lockdown began on 25th of March, which ended on 14th of April. Phase 2 went on after that, and phase 3 and phase 4, which lasted until 31st of May. And after this date, Government of Maharashtra initiated Mission Begin Again, which was slowly reopening its economy and day-to-day services. But side by side, as we heard from Pakistan's presentation also, there were some localized mobility restrictions imposed in some places in Maharashtra as well, which continued until now. And just recently, Mumbai, which was worst affected district and also city in Maharashtra, reported 0 deaths just few days back. So that is the whole journey of the state right from the beginning until now. So what we did for this study was we collected data from the very first day, March 9th, when Maharashtra state reported its first COVID-19 case, until May 31st, which was the last day of the severe mobility restrictions imposed. And we mapped epidemiologic trajectory using that data, estimating reproduction number, how much the how much infectivity varied across the time period. And what we did most importantly was we compared that infectivity to the scenario where we considered what might have happened if those severe mobility restrictions were not imposed. What might have happened when virus was allowed to infect people without any restrictions. So those two scenarios we actually compared in this study. And not only that, we also estimated, we compared the cost for those two scenarios as well by calculating direct costs involved in hospitalization, medication, PPE kits, ICU care, and also indirect costs such as loss of wages, loss of income due to death. All those costs we included in this analysis for comparing mobility restrictions versus not mobility restriction scenarios. So this graph and this table gives the idea how the infectivity decreased over the period of time in those 84 days. As you can see here, the reproduction number went down, and it was this number was actually smaller in initial days because cases were not realized at that time. But if you see at the beginning of that lockdown, the earlier infectivity was showing the results, and the infection was actually spreading, started spreading a little bit rapidly. And that's why the case doubling rate was very shorter at that time period. But as lockdown progressed, the infectivity was brought down because of this severe mobility restrictions, because citizens of Maharashtra followed the guidelines to the larger extent. And the case doubling rate was also actually came to 45 days at the end of that lockdown. This graph gives you an idea how that infectivity, the reproduction number, fluctuated over the period of time in those 84 days. As you can see here, it was very high in initial days of those mobility restrictions measures, and it actually brought down to almost 1 when that lockdown or severe mobility restrictions deadline was actually closing up. So, as I've mentioned in my method section, we also compared the cost for the actual number of cases reported and the scenario where virus might have allowed to actually spread unrestrictedly. So, using the methods available to do this analysis, what I found was the cases might have reached to almost 600,000 in the same time period if those mobility restrictions were not imposed during those time period. And you can see here the deaths might have reached to 25,000 as compared to the actual reported 2,000 deaths for the same time period. And if we go to the calculating costs for these two scenarios, by actually imposing these restrictions, the system was able to actually save almost 194,000 million Indian rupees, which amounts to 2.6 billion US dollars. So there was, from systems point of view, there was almost 84% cost savings. If we consider the total value of the deaths and total number of cases averted because of this mobility restrictions. So that was an important result from this study. So what we can say, as I'm just referring to, what has happened because of these severe mobility restrictions is Maharashtra state was able to delay the surge of cases in its initial days. And not only that, it was able to save the costs because of so many lives and so many infections were prevented during that time period. So this is the overall conclusion of that study. And now what happened after that initial time period? So I don't know if you can see my cursor, but this was the time period where those mobility restrictions were imposed. And you can see here there is a small kind of a hill which marks the first wave of the pandemic in India. So there is no huge spike here because the severe mobility restrictions actually pushed all those infections, delayed those infections, and there was a first wave, but the impact was spread out and not that much severe during that time period. But if you see the second wave, which came in around February and which lasted around until, it is still going on if you see the cases, but more or less we can say it lasted until September. You can see the high, like huge surge in COVID-19 cases in the country, and it was reported everywhere. Similarly, number of deaths you can see here. The number of deaths actually were reaching almost 5,000 per day at the peak of the second wave. And as we all know, the literature, scientific literature suggests these cases were mostly caused by Delta variant, which was rapidly spreading across the populations in India. So during second wave only, Government of India started its vaccination program around somewhere in January 2021. But still, we can see this is the latest data from almost 24th October. You can see India was able to only fully vaccinate 21% of its population. And as we know, to reach herd immunity, we have to inoculate almost 70% population. So the virus spread is restricted. Here, this slide also shows the other countries' progression, like Pakistan was able to reach 16.8% until 21st of October. Bangladesh is 11.8. And other countries, China, United Kingdom, United States, have inoculated a large number of its population already. The right side of the graph, here we can see the 23rd, 24th of October is marked by this dotted line. And you can see here, government in India, only 21% were able to get its 2 doses, and almost 50% have got at least 1 shot of COVID-19 vaccination. With this pace, even though we have inoculated almost 1 billion doses in the country, the projection shows it will take almost end of this year at least, or maybe longer than that, to reach 60% 60% coverage for this vaccines. So that is that was in nutshell what the progression looks like in India for COVID-19 pandemic. Now I will briefly discuss what were the implications, what were the impact of this pandemic, which were felt throughout the health system, throughout the society, and of course on the economy as well. So if we look at the health system impact, there was uneven health services disruption. What I mean by this is, states like Kerala, they quickly actually regained their non-COVID health related day-to-day happenings. They were quickly rebounded, and they started focusing on the maternal and child health care, non-communicable diseases, what was happening with their patients, and the data reporting was very strong from states like Kerala even during the pandemic, because they were able to actually control the pandemic, and then divert their attention to other pressing issues in the health system. But that wasn't the case for the other part of the country. The Bimaru state, as previously were known, Bihar, Madhya Pradesh, Rajasthan, Uttar Pradesh, which have a relatively weaker health system as compared to some of the progress states in the country. They were still grappling with the pandemic, and it overwhelmed their entire health system, and that's why there was as the literature suggests, there was less reporting, or there was a delayed reporting in terms of other health indicators like maternal and child health, and non-communicable diseases and other diseases. So few studies have reported it has impacted tremendously on other diseases. For example, almost 500,000 persons have missed their TB treatment. TB, as we know, is a very endemic in India, and it was a big concern before COVID-19. But because of this pandemic, many TB positive patients were not able to go to the hospital and avail the treatment. Some cancer-related research have reported that almost 60% of cancer-related surgeries were postponed because of the pandemic and lockdown measures which were implemented. And there is one interesting study which has reported that the hospitals actually faced there were less hospital deliveries as compared to the previous year when they compared the data. So all these things were affecting states, healthcare system differently in different parts of the country. And in many states, the majority of the healthcare resources, human resources, were diverted to pay attention to COVID-19 pandemic. Some studies have reported from the population that there were increased distress and anxiety because of COVID-19 pandemic, and also some studies are saying that because the COVID-19 pandemic was a priority, the funding for some programs might have diverted to actually to pay attention to the pressing need at that point of time. If we look at the economic impact, there are several projections, and IMF actually projected that India's GDP will grow in negative terms in 2020, and recently they have revised their projection for 2021, but still Indian economy will is supposed to grow by 9.5%. But if you compare the negative growth in previous year, so it's not more than 2% or hardly 2% GDP growth. Some studies have reported there were millions of informal sector jobs lost during this time period, and because of this, as ILO report, International Labour Organizations report suggests, there will be almost 400 million workers working in informal sector in India might have pushed into poverty because of this pandemic. And most recently, 2021 Global Hunger Index was published, where India is standing at 101 first position out of 116 countries. So those are some economic impact of this pandemic. If we look at the social impact, there is a reverse migration of workers working in informal sector in cities. They went back to the villages, and they again coming back to cities, and there is migration, reverse migration going on back and forth. Those are imposing some challenges at societal level as well. And most importantly, this pandemic have affected women and lower caste communities very badly. As this study is suggesting, there are less re-employment chances for women and lower caste individuals as compared to their counterparts. There is a trust deficit and stigma, which actually caused a lot of challenges during this pandemic. As my colleagues, while discussing their Pakistan study, actually mentioned, same sort of scenario developed in India as well. recently one study suggested that there were a rise in suicidal cases in some of the metropolitan cities, like in Haryana, in Andhra Pradesh somewhere, and in Kolkata. There were almost 3 waves of suicides happened during this entire last 1.5 year. And also there were increase in domestic violence on women, almost by 45% during the just immediately after the lockdown, as reported. So these are the impact of COVID-19 pandemic on India's diaspora. So what we can learn from what I've just discussed, my study and socioeconomic impact and whatever the progression is in India for COVID-19 pandemic, health and economic crisis cannot be separated from each other. We have to understand this point. And that's why it is very important in countries like India, where already the socioeconomic divide is so wide. We have to address those. We have to keep addressing, in fact, those socioeconomic disparities, no matter if a pandemic is there or not, because not addressing them actually worsens the situation. That's we can say. Also, there is a need to integrate social support services and whatever social support mechanisms we have, to integrate them with our health system plan, especially for calamities like this pandemic. We have to integrate this both system. They cannot work in silo. And lastly, there should be no ad hocism. What do I mean by this is, during my literature search for my study, I found that the initial expenditure or procurement from various governments were just focused on purchasing medication, purchasing PPE kit and ventilators to tackle the first wave of COVID-19 pandemic. But as we know that afterwards, the country faced a huge shortage of oxygen, and there was no, even though there were some technical group reports suggesting we should be preparing for this, we went on just having a knee-jerk reaction to what was happening on the ground. So in future, we should learn there should not be a knee-jerk reaction from health system. We need to have a stronger health system plan which can cope up to any kind of issues which might arise. So that is a one important lesson we can learn from COVID-19 pandemic. That's all from my side. These are the references. And yeah, thank you.
Thank you, Preshit, for the comprehensive review and shining light on some of those very important and crucial factors which you rightly pointed out pre-existed pre-pandemic, and most important, the socioeconomic divide and the inequities that exist in Indian society. And as we saw globally, those kind of socioeconomics got even worsened for those people living on the margins. The same was true for United States and Canada, but the countries where the socioeconomic conditions were so detrimental, like in India, you can just imagine the plight of those individuals and families. So maybe if you guys have any question for Preshit, Sajjad and Imran.
It was a nice and elaborative presentation, Preshit. Like Yesterday, me and Sajjad were also discussing this thing, this disparity between the lesser infections in Pakistan and as compared a much higher prevalent cases in India and other countries of the region. We were just discussing the reasons behind it. Like what I can say here is the younger age, average younger age people in Pakistan, the underreporting of the data, people not coming to the hospitals. But I just want your opinion on it as well. That what are the reasons behind we're not in Pakistan we are not getting the disease out of control like it went out of control in Brazil and in those countries. Like there is a wave and suddenly the cases drops down and everything is again everything comes to normal. So if Dr. Preshit and Dr. Smita, Dr. Pakhale, your opinion on this.
Imran, your voice was little bit, on the lower side. If Sajjad, if you have heard him, can you repeat? Or Dr. Pakhale, if you can repeat.
No, it was very muddled for me. Maybe Imran, you can type the question in the Q&A.
You know, the question was, I think
I don't know, suddenly the audio
I can tell the
has deteriorated.
Yeah, so the question was,
I think Sajjad can repeat it if he has heard because we have discussed it the whole day yesterday.
No worries.
The question is that I think he is referring that why the COVID-19 infection rate or hospitalization rates were not that high in countries like Pakistan as compared to Brazil or even India. In India, the second wave was big, but still you cannot compare it with what happened in Brazil or what happened in the US or UK or Italy. So he's referring to that. That what could be the plausible reasons for that.
So, in my limited reading, what I've, what I can tell is maybe Dr. Pakhale is pulmonologist. She can, maybe throw some light on this, why there is so much differences. People are referring to health system response as well, underreporting and all those factors, as Imran was hinting, and there might be also a difference in how virus has progressed across the countries, and we are actually we are trying to look we are trying to see the pandemic through the same lens for each country, and that might not be a good approach. There might be some local factors very different even in Pakistan, and when we compare to India or maybe some other countries, which might have caused differential spread of this disease across the population. I don't know exactly what those factors are, but there is literature is hinting in initial time period, everything what we were looking for COVID-19 pandemic was through the lens of China, through the lens of USA, UK, what was happening in European countries. But as it is suggested, like even in India, the fatality rate was reported very less. Even if you consider there is underreporting, still there might be some there might be some consideration we need to give why that was the case in these countries. So there might be some biological factors, maybe some other factors. I'm a health policy analyst. I'm not a geneticist, so I cannot refer to those things. But maybe that's all I can think of. Dr. Pakhale, do you have any insights like why countries had a differential, spread of COVID-19?
Sorry, I can't hear you really.
I think we are reaching the time.
Okay.
Yeah, it's like
7 o'clock, right?
Are we talking about underreporting?
Yeah. And Dr. Pakhale, I guess we are reaching time. 7 o'clock is the right. Sajjad, if I'm not wrong.
Yeah, I think
Yeah, we only have 1 minute left. It's almost like it's 4 p.m. here, so I think we are.
Okay, so Dr. Pakhale, can maybe I will hand it over to you to conclude.
Unfortunately, the audio has deteriorated quite significantly, and I'm not able to hear any of you clearly. But that was a great discussion, and I do not see any audience questions. Um, so thank you once again for all the panelists, co-panelists, and thank you for all the organizers for organizing this event and also giving us the opportunity and privilege to present on this podium. So thank you very much. Have a great day.
Thank you all. Thank you.
Thank you very much. Thank you very much, everyone. Thank you, Preshit, Dr. Pakhale, and
yeah,
Dr. Sajjad for
yeah,
being here.
it was a great discussion. Thank you. I'm not sure how it will just close
They said
down.
you have just leave the screen like there'll be no warning, etc. from the organizers.
Yeah, you can
I
just
think
leave on click on leave, and that's it.
so we have to click on leave and just the thing will be finished. I think there is someone
Have
from
to
the
leave the
organizers.
screen.
Okay. Okay. Thank you. Thank you very much.
Thank you.
Thank you.
Thank you all.
Thank you.